thank you. I appreciate being able to talk to you. It's really been an incredible journey for this last year. It's only been a year, so in terms of longitudinal effect, we can't really talk about it. But the startup and training all the physicians at UF and Shands Jacksonville has been an eye-opening experience, because what we're really talking about is trying to change the behavior of some very well-established and successful people, people that have been doing interview techniques, patient care, crisis management in a very stereotypical way for 20, 30 years. As you would imagine, the spectrum of acceptance from a group so large and so successful was very varied. Since I'm the first person, and perhaps there are those that don't really know the mechanics of the course, I thought I'd just take you through a very small view of it. It was composed of both didactic and role-playing skill sharpening. The didactic was fairly stereotypic. I imagine each of the institutions used the very same slides. We had a little bit of leeway to change it as we saw fit. But I think the tone probably varied among each of the institutions in the role-playing and how the facilitators interacted with the individual participants. What we tended to stress was, as Bill said, connectivity and trust, in that the physician has such a short period of time, or the provider has a short period of time, to reach out to the patient and establish a trust that would last the length of the therapeutic relationship. And so how do you sit in front of somebody and establish that connectivity in a short period of time that you have, given the financial constraints and the increasing number of patients needed to be seen? How do you establish a lasting, trusting relationship? And so the components of the course involved two basic techniques. One was to facilitate the patient telling their story in their entirety. It's probably no surprise that the data shows that physicians interrupt their patients on an average of 18 seconds into their story. The need to control the interview, whether it's for time constraints or other stresses, is overwhelming. So the first part was to teach the providers how to let the patient express themselves and to sit back and facilitate that, and during that period of time, establish an aura of trust between the provider and the patient. The second was how to promote connectivity, and that was by recognizing the emotional responses that the patient was giving you, be it anger or fear, frustrations, or any of those any of those emotions we see from our patients, how to reach across and utilize those emotions in a way to connect with your patient, to actually proactively seek opportunities to establish trust, not to let the emotional opportunity go by lost forever. So there were 4-hour sessions for faculty attendings and 2-hour sessions for residents. And in that time, we tried to urge them to let go of any other thoughts that they were, any other stresses they were experiencing, and to commit themselves to a new way of behavior. Bill gave each of the institutions certain questions to try to address. And in the case of UF and Shands, it was basically, why did you do it? How did you do it? And who did you do it for? What did you experience in teaching this diverse group of providers? What did you learn? And then what are you going to do about it in the future? The program started under Dr. Robert Nuss, who was dean at that time, who committed the financial and emotional effort to this operation. And the objectives were pretty much standard, as everybody would imagine. One, it was to increase patient satisfaction by creating a new culture where there was a new connectivity between physician and patient and a new trust. The other one was to try to diminish medical errors that would come about from incomplete data gathering, especially the historical gathering, to let the patient say exactly what was on their mind so that satisfaction was not just in the medical realm but also in the emotional realm. Some sub-goals were to facilitate cooperation between colleagues, and as you saw from Bill's slide, it's a powerful technique to make people treat each other in a more compassionate and connected fashion, not only between patient and doctor, but between colleagues. And lastly was to begin to move the whole institution to a patient-centered care model. But we also found that one of the other objectives that came out was to improve the provider satisfaction. That as we sat and talked about what bothered you about being a provider in today's environment, that there was a lot of frustration from different patient encounters to the stresses from the financial model, et cetera, and that people were going home much less satisfied with being a provider than they ever thought they would. And so one of the byproducts was, could your day-to-day interaction with patients be more satisfying? Could your interaction with colleagues be enhanced so that you felt more fulfilled in your day-to-day activities? With over 700 medical providers, the task in teaching all of them over a year's period of time was daunting, and the financial impact a little bit overwhelming. Over $250,000 in productivity time was lost doing this, but there never was any wavering that this is something well worthwhile. We started off by trying to get buy-in at the senior level, recognizing the fact that if the department chairs and the University of Florida senior management was not totally committed to this, that in the difficult times we would not have the ability to sustain the program. And so we took our first teaching episodes with the department chairs. As you can imagine, very successful providers, researchers, academicians, who had a long history of successful patient encounters, who in their own mind had really no need to enhance their communication skills. In fact, one of the interesting surveys that we did with them was, how do you rate yourself as a communicator? And it was exceptional. And then how do you rate your colleague? And it was average. So clearly a group that had a very high opinion of their success, and one that you would think that as you try to teach them how to communicate better may be fairly resistant in new techniques. But surprisingly, the overwhelming majority of these department chairs and senior leaders recognized in themselves that there were ways, a new way to look at this connectivity and the building of trust. And that if they just gave up control, they were able to establish a more therapeutic relationship. I'm not going to say that it was an aha moment, a tremendous catharsis. There were no tears. Nobody spoke in tongues or wrapped serpents around themselves. But you could see in a lot of them that they became advocates of the program, and they actually became insistent that their own physicians follow this path. So we felt that after training the senior management, that we had a good start in them being conduits to their department members. We then subsequently included senior leadership at Shands, who also were very interested. And although they may not have been in the patient care arena on a day-to-day basis, they were in the relationship business. And I think they did also buy into the fact that in dealing with physicians or dealing with their colleagues, there was a way to enhance their connectivity. We then addressed the fact that we had to train all the attending faculty, that was over 400 physician providers, as well as addressing how are we going to teach the medical, the residents, over well near 400 residents. And so the decision was made to give every faculty member a 4-hour course that included didactic and skill enhancement, and on the residents to give them a 2-hour course that included only the didactic. And what happened was that they would, all new incoming residents during their orientation got the 2-hour course. In all, there were 8 facilitators who did this on a regular basis. I have to say that when I look back to September of 2010, as the 8 facilitators from UF and Shands started doing this, we had a lot of trepidation. I remember asking our facilitators, what about the unruly participant who could sabotage? How did you do this? We had a lot of concern that training such a diverse group would have universal success. And I guess our facilitators must have practiced this course because they were uniformly calm and let us express our fears. And I have to say that 90% of our fears never materialized. That for the most part, surprisingly, even the most heavily egoed providers were able to set that aside and perhaps have a moment of introspection that allowed them to, and they were not all psychiatrists, by the way. I have to say that after a year, when you do this 2 or 3 times a month, you actually become fairly good at it. We did the first course in the fall of 2010, and here is just a breakdown. You can see the diversity from the different departments. Every attending got trained, some kicking and screaming, but by the end, they were in it. And in total, 902 participants were involved. So we had a fairly extensive experience. We gave 34 courses. And as I said, the attendings had 4 hours, the residents had 2 hours. And one of the things that we decided at the time was to do residents and attendings separately. And I want to go back to this in our impression of perhaps, as we move forward, an alternate way to do that. So what did we learn from this? Well, one of the things was that it's tougher to train attendings. These are people who've had very successful patient encounters, and so they're more resistant to new techniques of communication. But among that group are those that had a lot of bad patient encounters. They were able to remember experiences in which their communication skills didn't quite hold true. And so out of a group, there always were champions that stood up and would give examples of how this new communication style could enhance their practice. And having those champions stand up made all the world, because it gave credibility to younger attendings or other people. And I think that if we mix the attendings and the residents, that having residents look at attendings who have so much experience and have them validate the usefulness of this course would be a tremendous opportunity for the residents and buy-in for the residents. The residents, on the other hand, were easier to teach. They didn't have the long history of successful patient encounters in which to say, I already know how to do it. So they were more liable to embrace a new model of communication enhancement. But I will tell you that what we did learn is that behavioral modification is tough. And having one 4-hour session doesn't do it. I believe, after doing this for a year, that if you were to videotape a medical provider interviewing a patient prior to this course, that they would have, their techniques in interviewing would be fairly stereotypic of themselves. They would do the same things over and over again. They've practiced this behavior at times for 30 years. Having them break that, having them sit back and say, tell me what else is bothering you without interrupting, completely changing the way that they interact with a patient, looking for opportunities to emotionally respond to a patient at every opportunity when it might not have been the MO previously, is hard. And I don't think that we should underestimate how hard behavioral modification is to successful people. And so one 4-hour course is not going to get it done. I think that for senior management of the practice and the hospital, that the more that they can come on board and have successful encounters using this, the more they will be advocates. And I think that overall, if we move forward, the important thing is to bring this into the department and have champions. So let me just show you some. Overall, our program had 4.49 success out of 5. That was the evaluation. This is our patient satisfaction scores. They've moved up a little bit, but right now patient satisfaction is so multifactorial. I think that it's too early to tell exactly what's going to happen. That's the Shan scores. And so the last thing is that we want to move this into the department. If we're going to have continuing production of this course, it's going to have to get down at the grassroots level. We've trained facilitators. We're going to have to train more. It's going to have to be the department chairman that insists that their departments operate in this fashion. And it's going to have to be a daily expectation of behavior to break old patterns that are long established. Thank you.
Thanks, Alan. If you'd like to even take some paper to write questions down, after the four speakers are done, we are going to break up into some work groups, and we'll have a chance to answer those as well as some other questions. So if there are things that come up, please write them down, and we'll have a chance to address them then.